Myocardial infarction, commonly known as a heart attack, is a medical emergency where blood flow to the heart muscle is abruptly cut off, causing tissue damage. Angina pectoris, on the other hand, is chest pain or discomfort that occurs when the heart muscle doesn't get enough oxygen-rich blood. Symptoms of myocardial infarction include intense and persistent chest pain, shortness of breath, and sweating, while angina typically causes chest pain that may feel like a squeezing or pressure and can radiate to the arms, neck, or back. Treatment for myocardial infarction often involves a combination of medication, lifestyle changes, and possibly surgical interventions, such as angioplasty or bypass surgery. Angina can be managed with medications and lifestyle adjustments, with a focus on preventing progression to a heart attack. Risk factors for both conditions include high blood pressure, high cholesterol, smoking, diabetes, and a sedentary lifestyle. Here's a detailed exploration of each condition, their unique and overlapping aspects, and the critical implications for heart health. Onset speed, sudden versus gradual. Myocardial infarction, MI, and angina pectoris are both conditions related to reduced blood flow in the coronary arteries, yet they present distinctively when considering onset speed. MI typically announces itself with sudden, intense, and persistent chest pain, often described as a sensation of pressure, tightness, or squeezing. This pain may last for several minutes or longer and is not relieved by rest or nitroglycerin, a common remedy for angina. In contrast, angina pectoris commonly features a gradual onset of chest discomfort triggered by physical exertion or stress and is relatively short-lived, usually subsiding within minutes after the triggering activity ceases or with the aid of medication. Understanding this difference is crucial as it guides timely and appropriate medical intervention. A rapid response is essential in the occurrence of an MI due to its potential to cause irreversible damage to the heart muscle. Symptom duration, prolonged versus transient. The distinction between myocardial infarction, MI, and angina pectoris hinges on symptom duration, among other factors. In MI, there's a complete, prolonged interruption of blood flow, causing irreversible damage to the heart muscle. Symptoms are intense, extensive, lasting 30 minutes or more, often not relieved by rest or nitrates. Conversely, angina reflects a temporary partial decrease in coronary blood flow. Symptoms, while similar to MI with chest discomfort and possible radiating pain, are typically shorter, usually under 15 minutes, and can often be alleviated by rest or angina medication like nitroglycerin, indicating less severe yet still significant cardiac compromise. Trigger factors: rest versus physical activity, stress. Myocardial infarction, MI, or heart attack is typically caused by the abrupt blockage of the coronary artery, which starves a portion of the heart muscle of oxygen, often resulting in permanent damage. The onset of MI can be sudden and isn't necessarily related to physical activity or emotional stress. Angina pectoris, on the other hand, generally arises due to chronic coronary artery disease, leading to transient episodes of chest pain. It's often triggered by exertion or emotional stress, as the diseased arteries cannot meet the increased oxygen demands of the heart muscle during these activities. While rest and medications like nitroglycerin usually relieve the symptoms of angina, they do not resolve a heart attack, which is a medical emergency and requires immediate intervention. Understanding these trigger factors is critical for the accurate assessment and timely management of these potentially life-threatening conditions. ECG changes, persistent ST elevation versus ST depression T-wave inversion. The ECG electrocardiogram changes in myocardial infarction, MI, and angina pectoris are critical for differentiation and timely management. In MI, persistent ST segment elevation is a hallmark indicating a full-thickness cardiac muscle injury and an ongoing infarction. This finding necessitates prompt intervention, often a coronary angioplasty or thrombolysis, to restore blood flow and limit heart muscle damage. Conversely, angina pectoris, particularly unstable angina, is typically associated with transient ST segment depression or T-wave inversion, reflecting ischemia that is reversible and not yet resulting in extensive myocardial damage. These ECG changes often normalize when the patient is at rest or upon relief of the ischemic trigger. The distinction between these ECG presentations is crucial, as it influences the urgency and type of treatment, ranging from medical management with anti-anginal medications to invasive procedures. Response to nitroglycerin, poor versus good. When it comes to differentiating myocardial infarction (MI) from angina pectoris, the response to nitroglycerin can be a key factor. Angina pectoris, usually a manifestation of underlying coronary artery disease, often responds well to nitroglycerin, a vasodilator that can alleviate chest pain by improving blood flow to the heart muscle. On the other hand, while nitroglycerin may sometimes lessen the pain of a myocardial infarction, its effectiveness is generally poorer in comparison to angina. The reason for this lies in the nature of the conditions. Angina is typically caused by transient myocardial ischemia, whereas an MI involves actual death of heart tissue due to prolonged ischemia, a situation where the mere dilation of blood vessels may not suffice to address the underlying damage. Therefore, a poor response to nitroglycerin may signal the need for immediate, more aggressive interventions, such as thrombolytic therapy or percutaneous coronary intervention, to restore blood flow and minimize heart muscle damage in the case of an MI.